begin.
Yes. Good day, everyone. I welcome you to join the webinar series on Public Health and Hospital Administration conducted by Parul Institute of Public Health. This is the second webinar of the academic year 2022-23 at PIPH. Since its inception in 2016, PIPH has been instrumental in spreading knowledge about public health and related contemporary issues, and hence, as a part of it, we organize various webinars so that we can gain insights from people working on field and we could grow and enrich ourselves. India will soon turn 75 years young, independent nation in a few weeks, and we are very soon going to be a part of that historic event. A youthful India with the median age of 29 years is a home to 253 million adolescents between the age group of 10 to 19 years. These people are a transient age group which require a lot more attention and a customized healthcare for them. That brings us to today's subject. I'm sorry. I'm sorry. Adolescent health and the resilience of government health institutions in addressing it. Our speakers have been having a huge experience of ground level work in developmental studies and people working with the NGO sectors. So I'm sure we'll learn a lot of things from them. I hand over now it to our speakers to introduce themselves and go on with the seminar. Please do so.
Hello everyone. I am Payal. With me,
Hello everyone, my name is Ankur.
we come from Orange Free Foundation. We both are the founders for the organization, and cumulatively we have an experience of 26 years into the development space. We are very fortunate to be a part of this webinar series because this topic, adolescence, is very close to our heart because a larger part of our career as well as our interests are overlapping with the adolescent issues and the strategies around it. So we are happy to share our strategies. We are happy to share the insights from the micro, meso, and macro level. And we are hopeful that we will have a meaningful discussions ahead. So to begin with, we are sharing a presentation with you guys, and we will take some time to explain our topics, and we will be happy to take questions afterwards.
I hope the presentation is visible.
Yes, yes.
Yeah, okay. So talking about the adolescent health and the resilience of government health institutions from Orange Tree Foundation, we will start with the presentation and a quote by Aristotle, wherein we see that how youth are very important to any nation. And if we educate the youth, we see that the fate of the country completely changes and we all progress. So this is how we start with the quote: all who have meditated on the art of governing mankind have been convinced that the fate of empires depend on the education of the youth. You must have all heard about young people, adolescent, youth. These are the words that come across as citizens of the country. We see these words being used interchangeably. We see these terminologies that they come across to you. There is a lot of there's a lot of intersection that we see among young people, adolescent, and youth, and we see that there is very small thin line, but it is very important to understand young people, adolescent, and youth. When Arundhati ma'am introduced us, we got to know that India is a young country. And why India is a young country? You must have heard about a lot of figures. So India has more than 50% of its population that is below 25 years of age, and 65% population that is below 35 years of age. So this is why we say that India is a young country, and we are happy that we are among the young people who are very energetic, who are very ready to take risk, who are doing new things, who are very innovative. So we are happy to be a nation of young people.
So to explain more onto all these three components, young people basically comprises of the age bracket of 10 to 24. which includes adolescents and youth. Why it is interesting that adolescence is a very crucial age, we will see that later. But see how beautifully young people captures adolescence plus youth. Interestingly, the National Youth Policy of India says that youth is 15 to 29. It was earlier 13 to 35 years of age. So now, if you are turning 30, you are no longer a youth. So, uh, okay, coming back to why adolescence is very, very important.
uh, Adolescence is important because they represent a unique period in anyone's life cycle. Uh, it is the period when young people are not young, no longer children, but they're not yet adults too. So that is why adolescent is one of the very significant period of your life cycle. And once you're adolescent, you make significant choices. And we see that adolescent, especially they are the age group when they come across puberty, when they are transacting as adults. So again, coming back to the situation, we see that India has 243 million adolescent population, which is highest in the world. And we are interestingly two times the population of Mexico. So this is like a very important stage in anyone's life. And this is a time when we're still not adults, but we are coming across puberty. And it is very dynamic, because sociological, cultural, and economic realities, they all come to us.
So, if we talk psychologically, the Erickson's 8 stages of psychosocial development says that this age group can be defined as identity versus role confusion. This means that the people who are in this age group are always struggling with maintaining their identity, and they will always have a role confusion of whether I'm going right in my personal or professional area. This is also the time when the students find their subjects. साइंस में जाना है, आर्ट्स में जाना है, क्या करना है, what will be, how I will be looked upon as when I come to adulthood. So this is a very crucial time, because a lot of things are happening in the minds of the people, and because they are going through puberty also, this transition period makes it more tough for them, because the physiological and psychological changes are very extreme in this age bracket.
Now, coming to adolescent, why it is relevant that their health is a bigger concern, because we all know that we are 243 million adolescent in this country. And adolescent, they make significant choices about their health. They develop attitude and health practices that affect their current safety and well-being. This is also a time which is like which will influence their risk for future serious and chronic diseases. So it is very important that the health strategy for adolescent is very robust.
If we see, the lifestyles and the behavioral changes are very much linked to the global burden of diseases. It is as much as 20 to 25%. So, what conduct we are going to do in adolescent is actually a reflectory when the adulthood comes in. 6% of the deaths are the main cause for 21 to 25% of breast and colon cancer, 27% of diabetes, 30% of heart diseases are also the reflectory indicators of what the people have been in their adolescence. 33% of the disease burden and almost 60% of premature deaths among adolescents can be traced down to adolescence. And this is huge. And the conducts, physiological and psychological, will lead to the non-communicable deaths in the future. So it is very, very crucial for adolescents to be tapped on the health strategies. Especially, I'd like to mention that post-COVID, the scenarios have also been changed. Post-COVID, the sedentary lifestyle have been extended for all of us, especially with the adolescents, because they were the one whose physical inactivity increased that time. Substance abuse its causes as well as its effects were very significant during this time period. And of course, mental health, which is largely unacknowledged, undiagnosed, and untreated. And post COVID, this has been seen with a very big surge. So, with all these factors in our mind, the relevance for the health strategies is very indicative and very important in this age group. If we talk, so now this slide, it is very disturbing because as we see, it gives a very exploitative way the women are forced upon into. The data says that 1 in every 3 married girls in the age of 15 to 19 experience violence at the hand of their husbands. 1 in 5 girls in the age of 15 to 19 years who experienced sex before marriage was forced. And 2 in 5 girls who were commercially sexually exploited were minors. These data are disturbing as much as the fact that post-COVID, the situation have worsened a lot. The data from UNFPA suggests that post-COVID, the access to the birth control methods, the access to health facilities by the adolescent girls, by the vulnerable group has many-folded. So with one case study, we'd like to basically understand how the meso and macro level data are manipulated, is conducted. So this is a case study of Ganeshi Meghwal. She was one of the peer educators with us when we were implementing Action for Adolescent Girls program, which was financially and technically supported by UNFPA. This was being done in one of the rural tribal blocks of Udaipur district. It was called Gogunda. So Ganeshi was coming from a rural background. She is tribal from her orientation. She was married at the age of 15 years of her age. Because she was married early, her education was discontinued. So when she went to her husband's house, she was forced upon on gender-based violence. She was also forced upon the mental health issues that was forced on her. But that was of course unaccounted, because when it comes to gender-based violence, it is always overpowering the mental trauma a girl goes through. So going through all this, she was living her life. She was balancing between negotiating between how to not get beaten up today. And at the age of around 16 and a half, she came back to her parental home, and she said that I will not go back. There has been a lot of going forth, but most of the time she was making sure that she stays at her parental home. Let me remind you, she was only 16 and a half or 17. This was the age group when she was onboarded with us with the Action for Adolescent Girls program. This was a life skills based approach program. It was a very extensive, comprehensive program which was focused on 3 assets: health, social, and economic. There she basically learned the skilling of bulb making, LED bulb making, through this life skill program. And currently she is an entrepreneur and a trainer herself, who trains other girls and women on making LED bulbs. She also represented India in ICPD 25 in Nairobi. So why I was sharing this case study? Because her situation will be able to tell us what exactly is happening in our country with the young girls, with the young boys across the space. So the risk involved with her were plenty. It were a lot. So if we talk about the risk, the access to right information, the modern family planning methods, the menstrual health management information were limited to her. Because she was young and she was married off early, the confidence level were also limited. Her reach to health institution was also a risk, because her socio-cultural dynamics put a lot of barrier to her to reach to these institutions. because she was also afraid of the judgment and not delivery of health services. She was afraid to access the health institutions. They Because she was married early, the risk of getting pregnant early was also something that she was battling with. This eventually would either lead to the IMR or the MMR data. The unmet needs for family planning could also be done and posted upon her. If she was not into the institutional deliveries, this would also reflect into the data. And of course, the limited education would limit her access to vaccination to her children, her own health, including anemia. She could also go into the substance abuse. So eventually going into the vicious cycle of poverty and poor health. So people like her, people like all the girls who are in rural and urban settings are battling with such risk every day. And how this is translated into the macro level data is something that we want to talk about next. So it is interesting to see that women in the age of 20 to 24 who were already married before 18, in rural setting it is 27% in India, and if we see in total it is 23.3%, which is just 3% less than NFHS 4, which was 5 years before. And let me remind you, the situation with men is no less bad. Men in the age of 20 to 24 who were married before the age of 18 had 21.1% of share, and the total share was 17%, and it was only 3% better off than the previous NFHS data. If we talk about the adolescent girls who were married or either pregnant during the time of survey, it was 7.9 in rural areas. That means about 1 in every 11 girl was pregnant when the survey was done. And in total, this was 6.8%, and this was just a little better off from NFHS 4 data. And because we can see the correlations very easily, that because the adolescent pregnancy was there is a crude enforcement of the premature adulthood with them, and this can reflect very easily into the infant mortality rate, because her mental and the physical state is not ready for giving a birth. So the IMR rates in India in rural setting is 38.4. That means every 38.4% of children die out of 1,000 death per children. In total, it is 35.2%, and this is just 5% better off from NFHS 4 data. So we are seeing a very clear demarcation that the NFHS 4 and NFHS 5, there is a very minor, very meager difference in the data, but it is a little better off. So that means that the resilience we are talking about the health system is actually shaping up very steadily. We need a lot of pacing up, but it is happening. If we talk about the households with any usual member covered under health insurance or financial scheme, it is 42.4% in rural. It is 41% in total, and it was very less, which is 28.7% in NFHS 4. Why it is reflectory like that? Because post-COVID, the government's interest into the health sector has increased. Not as much it is needed, but it is still has significantly increased. Schemes like Chiranjeevi Yojana in Rajasthan is something that is exemplary to see and to study upon, of how the power shift is going to in the hand of rural people to access their own health services. And this is very interesting, and we are hopeful that this increases in the future, so that the utopian dream of everyone having access to healthcare, quality healthcare services, is achieved. If we talk about the female sterilization, 38.7% female sterilization is happening in rural, and in total it is 37.6. We can, this is a very important data, because this says that out of all the modern contraceptive methods, this is the largest contraceptive method that is being done, and it is being done upon women. So this also shares that the burden of uh, population control, the burden of family control practices is on women. And this has been just 2% increase from NFHS4 data. And this is not just it, because upon the health indicator, which are very directly focused on adolescent girls and women, young women, there is a lot of the things that is happening in the adolescent space. This there has been a steep increase into non-communicable diseases and death by non-communicable diseases currently in early adulthood and adulthood. And of course, like we were sharing, that the lifestyle and behavior are linked to 20 to 25% of global burden of the diseases. That means that what conduct we are having during our adolescence is directly proportional to the causes that are there for the death in the adulthood. So we have taken 4 parameters which are directly related to adolescence, and which has got direct proportion into the death by non-communicable diseases. So we are taking 4 causative risk factors: tobacco use, unhealthy diets, physical inactivity, harmful use of alcohol. And due to this, there is a high possibility of having 4 non-communicable diseases, that is heart related, diabetes, cancer, or chronic lung disease. So if we talk about tobacco use, this table basically says that how prone we can be because of these causative risk factors. So tobacco is covering all the 4 diseases, and the unhealthy diets, which is increasing day by day, because now the street food culture and eating outside is becoming more frequent in urban as well as in rural setting. The unhealthy diet practices by adolescent is at an all-time high, and this increases the risk of heart diseases, diabetes, and cancer. Post COVID, the physical inactivity have seen a bigger steep. There has been an explosion of exposure, access to information, and implementation gaps into the programs. There has been a reported increase in inactivity physically all across the age groups, especially during the adolescence. And this lifestyle can be very complicated and invite heart diseases, diabetes, and cancer. And due to the unaltered and unattended mental health issues, the adolescents are also going towards the harmful use of substance abuses like alcohol. This is also affected by the portrayal of alcoholism into the social media and into the informations around us. And this is directly related to heart diseases, diabetes, and cancer. This table is actually very interesting, because this actually tells how these causative risk factors are cascading to the adolescence, to adulthood. And we will see that all the ticks are there. That means all these causative factors are usually starting or is being reinforced in the adolescence. The earlier it starts, the more serious the problem gets. It is very likely that it persists in adulthood also, and the negative repercussion starts during the adolescence. This eventually leads to evidence-based intervention available. So this is very interesting, that how all these causative factors are cascading to the adulthood. And not just this, the media around us, the social media influences around us, they and the peer learning, the negative peer learning is also leading to the negative masculinity problems. More than 80% of men witness an incident of physical violence perpetrated by men against a woman in their home during childhood. So you will understand that if 8 out of 10 people are uh, uh, getting reared with seeing all these things at household, what impact it will have in their heads. And out of these 80%, 90% of the people themselves experience physical violence in home. And according to the same research which was done by ICRW, two-thirds of the reported are being physically violent against their another child or youth in schools or communities. So how the mere the witness of violence is percolating to the physical act of violence also. This is a risk because this leads to the mental health issues, this leads to the substance abuse issues, and this leads to eventually leads to the skewed health parameters. And if we see that how this picture is being seen in the macro level, according to the latest NFHS 5 phase 2 data, women in the age of 15 years and above who use any kind of tobacco is 10.5%. So if we say that tobacco is for men and they are the one who are the customer of Zuban Kesri, this is not it, because 1 in every 10 rural women are actually consuming tobaccos. And in total, this data is 8.9%. This is the new data introduced in NFHS 5, which was not there earlier in the previous NFHSs. And this is interesting to see because this is also a very causative risk factor for the health parameters. In men, the same parameter is 42.7% in rural and 38% in total. The next component is consuming alcohol in women in age 15 and above. It is 1.6% in rural and 1.3% in total. I highly doubt that this is underreported, and because the same thing in men is 19.9 in rural and 18.8% in urban. However is the data, however is the thing, it is worrisome because this leads to the health hazards in future. So why all this thing is interesting? Because we talked about the SRHR issues, we talked about the mental health issues, we talked about the substance abuse and the causative risk factors. This is a clear indication that only taking one component is not enough. We need a multi-sectoral, we need a holistic approach to address the adolescent issues. And if we want to talk about the reproductive and maternal and child health care, we can't leave the adolescent behind. So this slide basically shares the trajectory of how the maternal and adolescent health programs have been seen in India from its inception. It started from 1946 when the Bohr Committee recommendation came in. With us, there are a lot of students of public health are associated. I'm sure you will be learning, or you must have learned already about the committee and its recommendation. This eventually led to the National Family Planning Program, and through the series of programs and structures, we have now come up to RMNCH plus A. There is an addition plus A, which is adolescents, because of course, the multi-sectoral and holistic approach is the call. And in 2014, RKSK, the Rashtriya Kishore Swasth Karyakram, was launched, and this was launched taking into considering all the stakeholders that could be relevant for adolescents. So this the diagram that you're seeing currently presently is capturing all the stakeholders that are possibly associated, that are possibly relevant for an adolescent. So you will see that the inner circle, you will find your parents, your siblings, your ASHA worker, because the primary health services are given by ASHA, teachers and their peers. We move a little forward, then we will have Anganwadi workers, we will have literacy freaks, we will have Nehru Yuva Kendra volunteers, we will have relatives and peer educators. Peer educators is a very key responsibility, because adolescence is the age where we don't like anybody else to get preachy for us. We learn from our peers very happily, and we get very pissed off if an adult say the same thing. So peer educator strategy is proven to be very interesting and relevant for these adolescent girls and boys. If we move a little forward, we talk about the gender based violence, we talk about their engagement, their positive engagement with the institutions and the community. The child protection officers, ANM, village health and sanitation committees, SHGs, school development management committee, PRIs, and local media and police becomes the key stakeholders. We move a little forward, we will find that the sub health centers, homes, school, Anganwadi centers, adolescent friendly health clinics, workplace interventions, youth recreation spaces, and interest, very important, vocational training and education centers are there. So tapping into all these stakeholders, the approach for RKSK was being done. This covered the health risks of the and behavioral risks of the adolescents, and this answers the positive youth development strategies. So substance abuses, diet and exercise, injury and violence, sexual and reproductive issues, and social issues were covered into the scheme, and a positive engagement was ensured. And this was done in six important components, but which is nutrition, sexual and reproductive health, injuries and violence, non-communicable diseases, substance abuse, and the sixth one is mental health.
So in the previous slides, we have seen that what are the health challenges that we as adolescents face during their life cycle. We've seen that how these challenges are immense, and we need a very strong multi-level, multi-sectoral solution for the various and the diverse needs that the adolescent have. So it is very important that the health structure should be very robust. That's why we see that the Indian health system, we have Anganwadi centers. Anganwadi center is one of an center which is a part of the ICDS, Integrated Child Development Services Scheme, which caters to the most primary level, which is comes under the primary level. This is a center which provides supplementary nutrition. This is a center which provides preschool and non-formal education to children who are less than 6 years of age. This is a center which also provides nutrition and health education, because the nutrition needs are very immense. This is a center, this one-stop center for all the immunization needs of the village or the community, and then health checkup is done on regular basis. For various services, the referral services also provided, which is like beyond the scope of the Anganwadi center. They are referred to the other center. After the Anganwadi center, at the village level only, we have a sub center which is established at a population of 5,000, and in some difficult population or in tribal areas, there is a guideline that it can be for 3,000 of population, and it is not uniform. It all depends on the area and the needs of the population as well. So if we talk about the sub center, it is again the first contact and the primary healthcare system for the community. And if we talk about the team members, here we have one ANM, which we call the auxiliary nurse midwife, and then a female health worker, which provides health facilities to the village communities. After sub centers, the community for their health needs, they can reach out to public health centers, primary health centers, which are commonly known as PHCs. And as per the guidelines, it is like it is established for population of 30,000, and in special cases it can be for 20,000 population as well. If we talk about the PHCs, they are very special into the primary health service cadre, because this is the first interaction. If there is some acute health issue, then the first medical officer sits here or is based out here, and then the community can reach out to them. Then if we talk about the other staff, we have other than the medical officer, we have 14 paramedical and other staff as well. And it also acts as a referral unit for 5 to 6 sub-centers, and it has 4 to 6 beds depending on the needs of the patient at the primary health center. Coming to the next layer, which is like the community health center, it is established for a population of 1,20,000, or in some special cases it can be for 80,000 as well. It is a center wherein the center has a specialist, which has a surgeon, a physician, a gynecologist, and a pediatrician. And there are other 21 paramedical and other staff which is based out at the CHC. It can have up to 30-bed hospital and an operation theater. It has X-ray, labor room, and laboratory facilities. So what we've seen is like we have the primary level, the secondary level, and the tertiary level, so that all the health needs of the population is covered. We've seen till CHCs, and beyond CHC we have the sub-district hospitals, district hospitals, and then at the tertiary level we have the district hospital and the medical college to cater to the health needs. We've seen that adolescent is a very special age group. We have understood that RM and CH, when Payal was talking about RM and CH, we've seen that this is one of the health strategy that the government of India has, and this is an approach where we are gradually shifting from a clinical approach to a health promotion approach, and we are clearly articulating and instilling the positive behaviors among adolescents. And this is what is a transition that is making them healthy, and it is like a healthy transition from childhood to adolescent to adulthood. So this is why this adolescent friendly health clinics are very important strategy, and they are being promoted by the government of India. We see that at the adolescent health friendly clinics, we have an information corner, and at the information corner we have the IEC, then we have issues for nutrition, sexual reproductive health, we have counseling for mental health, we have information on gender-based violence, we have information on non-communicable diseases, we have communication on substances use. They have short audio clips. There is a television and the audiovisual aids that provide short films and audio clips that provide information to the young people who come and receive the services. Along with that, at the AFH Adolescent Friendly Health Clinic, they are also provided with products such as iron folic acid tablets. They provide sanitary napkins. They provide contraceptives as well, such as condoms, oral contraceptive pills, and they also have emergency contraceptive pills as well. For the other medical needs, they have all the first aid kits, which includes paracetamol and other tablets. They have, in case if the adolescent needs pregnancy kits, it is also available at the adolescent friendly health clinic. And there is a BMI chart which will help them understand their body needs. And if we come to the services, we have BMI screening, we have hemoglobin testing, we have blood sugar testing. Then for RTI and STI management, there is services. Then there is counseling for antenatal and pregnant adolescent. There is counseling on nutrition, puberty related concerns, premarital counseling, sexual problem, contraceptives, abortion, RTI, STI, substance abuse, learning problems, stress, depression, suicidal tendency among adolescent, violence, including gender-based violence, sexual abuse, risk behavior, other mental health issues, healthy lifestyle. So these are the counseling areas. Then we have services for management of menstrual problems, a service for iron deficiency, anemia, screening for diabetes and hypertension, management of common adolescent health problem, HIV testing, management of physical violence and sexual abuse, linkages for de-addiction center, and the referral also works from here, and treatment for specialists and referrals.
So all of this would be possible only and only if the frontline workers and the people who are associated with adolescent friendly health clinics are sensitized, they are non-judgmental, and they are welcoming. These three components, very important they are. They should be sensitized enough on the adolescent issues and their problems. They should be very non-judgmental, because adolescents who are into a problem, they are stuck into something. When they go to the adolescent friendly health clinics, they would not want to be judged at all, because for that they have relatives, for that they have people around them who are very critical of their actions already. So non-judgmental, being very welcoming is something the people who are directly dealing with adolescents in these AFHSCs is very important. For that, the government and the technical agencies associated with them do periodical training with them, so that they practice non-judgmental strategies, they practice welcoming strategies, and they practice the interactive methods and facilitation, so that the adolescents don't feel intimidated while accessing the AFHSCs. Uh, like Ankur has shared, that AFHSCs has information corner, that any child, any adolescent would want to come here and understand and build their understanding on things. We are living in an era where the information overflow is there. You have your phone in your hand, if not in your hand, in somebody else's, but you have access to information so much so that the intelligence of negating the negative sources, negating the unsolicited uh, wrong sources is gets very important. And the primary information center is the key for it. There you will get a short information, uh, with no judgments on the look. There are products which are very directly helpful with the adolescents, because at this age they just don't need solutions. They just don't need information, they do need solution as well, and services that will help them access these products and information. So eventually, at the end, we would want to share that we all know that adolescent health and development is the key to achieve and improved health and development outcomes for the population as a whole. It is important that we engage with them and match their expectations. And this can't be done in a vacuum. This needs a very well thought of strategic collaboration, because collaboration is the key. Various ministries, development partners, multilateral civil societies, academicians, and the voices of those who matter the most, that is our adolescents, is important. And the complete synchronization of all these stakeholders will help us achieve the goal, will help us achieve and improve the NFHS 6, hopefully 7 and 8, hopefully. And eventually, when we will look back, we will see that the strategies with adolescents were helpful to change the picture of the country's national health and family parameters as a whole. So at this with this thought, we would like to close our presentation. Thank you, thanks to all of you to hear us out very patiently, and we will now break with the questions. So we can happily take the questions now.
Yes, now we are open to questions from.
We would also welcome the students to share the incidences they have heard or seen in their past, because they are also graduating from adolescence eventually, and now they have reached to the early adulthood. So they have just crossed the age group that we just talked about. So the insights or probably the experiences of people around them would be insightful to understand or maybe build upon what we have shared right now. Just to add to what we had shared, the NFHS is a very interesting indicator, a very interesting report that shares the crucial indicators for understanding the social realities of the country. So when we see the datas of IMR, MMR, we see the datas of institutional deliveries, we see the datas of anemia, we see the data of substance abuse in men and women, we see the data of unmet pregnancy, unmet needs, we see the data of modern contraceptive methods used by women and men. We do see that this is the aina for our society. We are seeing the macro picture, which tells the story of each one of us in a larger sphere. We do see that these crucial datas are increasingly improving, but needs a lot of improvement at hand. And this data is also sharing that the pregnancies during adolescence, a major share of them is under the wedlock. So it is not that the teenage pregnancies are happening outside the wedding. That means the marriage institution is still prevalent in the country, more so in rural setting than the urban ones. But the major teenage pregnancies are happening under the marriage institution, which is heartbreaking to say, because we are in the year 2022 and we are still struggling with the basic social issues like that, which eventually leads to the health problems of the next generation, of the generation to come.
Yeah. So one of the questions. Hello.
Yes.
Yeah. One of the questions. Um, can you give some highlights on adolescent health clinic? Is my voice echoing too much? Hello.
Yeah, it is echoing a little, but yeah, we can still hear you.
Yeah. So the question was, can you give some highlights on adolescent health clinics?
Okay, so talking about the adolescent health, it is basically the adolescent health clinics come under the Rashtriya Kishore Swasthya Karikram (RKSK), and adolescent health clinic is one of the strategy under the RMNCH plus A. This is basically a paradigm shift from a predominantly clinic-led service delivery approach to one that focuses on a primitive communication-led approach. This program expands the scopes of adolescent health program in India from being limited to sexual and reproductive health. It now includes its ambit to nutrition, injuries, and violence, including gender-based violence, non-communicable diseases, mental health, and substance issues.
And this adolescent friendly health clinics are based out of the values which are very interesting. It talks about the equitable, accessible, acceptable, appropriate, effective, and comprehensive strategies that will welcome the adolescent girls and boys, not just shoo them away, and uh, be very positive with their approach. Because eventually what you need as an adolescent, we do need a welcoming environment when we are in trouble and otherwise. So to we do need a welcoming environment when we are in trouble and otherwise. So we do need a welcoming environment when we are
We're not able to hear.
Hello.
Hello.
Yeah, we're not able to hear. Hello.
Yes, so we just shared about the adolescents friendly health clinics. We were sharing that this is based out of the values which are welcoming for these adolescents. It based on the equitability, which basically says that every adolescent is equal in the eyes of the services, information, and the products. It is accessible for them, it is acceptable for them. That means the health meets the expectations of the adolescents. It is appropriate for their age. It is effective and it is comprehensive in nature. Expectations of the adolescents. It is appropriate for their age. It is effective and it is comprehensive in nature.
Hello.
Hello.
Yeah, so the next question is, what are the basic terms for family planning in PHCs?
Basic products?
Basic terms for family planning in PHCs.
Basic terms for family planning in PHCs.
By terms, you mean terminologies, or the services for.
I think it is the basic services, but the question has been framed that way. But I think it is the basic services.
So the basic services for family planning includes the contraceptive methods. It includes the information about around them, and that includes the products like contraceptive pills, the oral pills that are being taken by the women counterpart. The kit also includes condoms, that is for the male counterpart. The kit also includes the uh, emergency contraceptive pills. It is heartbreaking to see that this has reached every Anganwadi center, because we all know that the emergency contraceptive pills are very risky to take if we don't have the full information about it, especially when we are dealing with adolescents, because adolescents who see the advertisements which says that within 72 hours the miracle happens and you can take this as many times as you want, as many as times you fall into the trap. This is very crucial for the frontline worker and the Anganwadi worker and the ANMs to have a thorough knowledge about it and give the information beforehand to the adolescents and the young women before giving away the emergency contraceptive pills. The kit also includes the information of the IUDs, the intrauterine devices. That includes copper T. It also includes the information about the other methods, but that can be accessed in the PHCs and CHC and the levels above, not at the Anganwadi center level. So there is a twofold solution. One is the information about things and the products. The basic products are placed at Anganwadi center level, and the products that are surgical in nature, for example, the intrauterine devices, that are there in the higher health institutions.
Yes, I suppose that this answers the question. The question was from Gaurav Kumar. Dr. Himanshu has asked how to increase the consumption of iron tablets among schoolgirls as well as women in reproductive age. It is a big challenge among community to accept. So how do we do it?
Yeah, it is a very interesting thing that whatever that comes for free by the government especially is always seen as degraded in the value, in the quality, but this is not the case. Ankur is sharing the experiences.
Adding to what Payal has shared earlier, there is a need for us to implement a lot of programs because we are all in the health sphere, and we want to ensure that the health facilities are more utilized and the health services are more utilized. For that, what we need to do is like there is a lot of scope for us to reach out to the population. We should mobilize more people. We should tell them the advantages of taking the tablets. It is very important that the community is educated on the issues of anemia and what are the challenges which can happen to anyone's health who is struggling from anemia. And this is why it is like as from the government side, we see that the structures are made very resilient at the first center, at the first primary health center. At the primary services at the Anganwadi center, the pills are available, and this is done in a way that the Anganwadi worker, she is always in touch with the community members. She knows the needs of every person who is under the periphery of this of the Anganwadi center. She has a local touch with the community. That is why she will be able to understand their health needs and make them understand that how the consumption of tablets should increase.
A very small initiatives by the Anganwadi workers and Ashas is that they themselves share their story that this is not reactive, the pills are safe to take, and the pills are good for you, is something that can be done. In our program, when we were implementing this adolescent action for adolescent girls program in the tribal blocks of Udaipur, what we did, we took the help of peer educators who themselves became the model for replicating the effects, rippling effects to the other adolescent girls as well. With the pregnant women, the case is a little different because they themselves are a little more secure about their needs and their nutritional needs. Plus, the ASHA worker is directly catering to each case one on one. So in that case, it is a little more easier. In the case of adolescents, we can take the help of the peer educators.
I think that answer, Dr. Himanshu, that answers your question. There are a lot of questions about how to how to handle mental diseases or mental issues in adolescence. Some
Mhm.
questions state that the mental disease is the root cause of most of their physical ailments also. So how do we do something to control their mental diseases?
Uh, we understand that mental health challenges are increasing every day, and the mental health diseases is also one of the reason for other health ailments as well. This is also we've seen that the health issues, they are unrecognized. It is very important that we have community programs wherein the community is made understood the importance of mental health. It is very important that the health services are utilized in a way that the community, they reaches out to the Ujala clinics. When I say Ujala clinic, it is especially for Rajasthan, for the NFHS clinic as well. Counseling is very important, where the AFHSC clinics, they provide the services for counseling. uh, it is very important that life skills are being taught to the young people, to the adolescent, so that they can understand and cope up with these challenges. And it is also very important that once you are into the adolescent friendly health clinic, you should continue with the counseling, and you should continue with the treatment. And if there is a need for referrals as well, the community members should continue with this. And this can only be created when the environment is very positive. It should be like conducive for the adolescent and for the young people, so that they do not hesitate. Like when we were doing the presentation, Payal shared that it is very important that the adolescent health clinics are welcoming. It is also very important that, and these services are ensured that the confidentiality of the information does not goes out, because adolescent age group is age group wherein they can feel embarrassed about the smallest of the thing. So mental health issues are of a very bigger concern, and we should have more community programs, so that people have awareness around it, and they should be going further for counseling and for the treatments as well. Payal, you want to add something?
No, so mental health is a tricky topic, because we are not yet prepared, because we most of the cases go unnoticed, and uh, whatever structures we have are not enough to address it. We are hopeful that in the future this will be taken care of, and being taken seriously, as the health professionals and as the people are also getting aware of. So as Ankur was sharing, in the preventive as a preventive method for mental health issues, the life skilling programs with these adolescents is very helpful. I want to share one example that we have done in our Action for Adolescent Girls program. We had a comprehensive curriculum with them, which was based out of life skills, and out of which one subject was positive and negative relationships in our lives. It is very crucial for the adolescents to understand that amongst my relatives and my friends are the positive ones for me, and who are actually putting me down through their negativity, and those who speak positive with us and have an ill intent are the negative relationships. And differentiating between these two is very crucial. And adolescence is also the age group when the people start getting romantic, uh, uh,
Towards the
to
partner.
they start exploring their romantic part also. So there it gets very crucial, because now to bifurcate between who has a positive intent, you this is also a time when the people are are thinking very rebellious for of their parents and their relatives. So how you manage your emotions and how you manage your relationship there is something which, if it is sorted in the first go, the half of the mental health issues will be mellowed down. So as preventive, the life skills approaches can be taken care, and in the curative way, the Ujala clinics, the and also friendly health clinics at the CHC levels uh, are the first hand institution that caters to this. And like Ankur shared, the treatment, full treatment, non-judgmental treatment is very important there.
Yes. Thank you, ma'am. I think you have given a very brief answer to majority of the questions that were emphasizing on the mental health issues of the adolescents. Also, I would like to add that personally, Ganeshi's case and the 3 points that you mentioned, there is a need of sensitization, non-judgmental, being non-judgmental, and having a welcoming environment is what India needs the most. I think if this is taken care of, the undiagnosed burden that we are having of mental diseases will be diagnosed, and they will also come to us. It will be better for us to provide them services also, and we will be in a better position to handle the big challenge, which is actually like an iceberg that we can only see the 10% of it, and the 90% of it is not visible. So I'm that was my personal favorite part, that you mentioned these three things. It was very nice and informative seminar. I thank both of you for your time. I also thank respected Dr. Apurva sir for initializing such web series. I also thank PIPH and Parul University, the IT team specially, for their support. And we will end it here. Thank you so much.
Thank you so much.
Thank you so much.
Okay.